this times that we're in. So we're working as contact tracers. So if a patient tests positive for COVID and they have come in contact with other people, health information management professionals are able to actually move into a new role as a contact tracer. They can also work as frontline staff um, to perform intake of patients, to perform registration of those patients. Uh, we find that some people are working as screeners. So if there's any testing taking place in your surroundings, any kind of COVID-19 testing, HIM professionals are really primed to work as screening those patients in any kind of mobile testing area. And also to the topic at hand, telehealth, as HIM professionals, we are also primed to work in that space. So there have been companies, I'm aware that there are companies that are been developing telehealth applications today. And so we are really prime as HIM professionals to work in that space as well, because we understand health data, we understand the clinical coding piece of it, we understand patient information and all of the different classification systems, ICD-9, CPT, and all of that. So we are really primed to work in that space. So bridging the topic for me today is really bridging the skills gap, right, for HIM professionals. As I mentioned earlier, globally, when organizations have started to implement any kind of e-health technology, we have been, as HIM professionals, at the forefront, or at least I hope that HIM professionals have put themselves at the forefront of that implementation. So a lot of organizations have moved from manual, so managing patient information on paper, and moving it electronically. Now, we have been able to put our voices to those kind of implementation because, like I mentioned earlier, we're able to understand patient information. For those that are yet to transition, though, if there are organizations in Nigeria that are maybe it's a little bit slower to transition to electronic health records, I believe that now, with this pandemic, with the understanding that a lot of organizations are now adopting telehealth and really now interested in adopting electronic health records and just any kind of e-health, then I do believe that as HIM professionals, we are able to participate in those efforts. So if there's a company that maybe comes to the organizations that you work in and they are pitching to the administrators to come in and deploy any kind of mobile health, we can, as HIM professionals, we can participate in building some of those technical applications for them. We can be involved in the documentation of those workflows, those new workflows. We can also participate in demonstrating how those applications will work for the organizations. When we come as HIM professionals, we're really the first step that the patient meets. When they come to the organization, we help them to manage their records. So we're well suited to be able to train people, new people that will be using the applications, and also just if you're a more experienced person, more experienced a professional, then you can also provide some kind of internal consulting support, right? So gathering all of the skills and experience that you have in health information, you can provide consulting support. Specific though to technology, right? So to e-health, I find that I am currently studying for my project management professional certification. So I just want to speak a little bit of some of the, first, to be able to breach the skills gap, right? So again, I don't want to belabor the point, but we are, as HIM professionals, we're very well suited in managing patient records, right? We know all of the classification systems. But as we move into as we stated here, post-COVID era, and also really move into a technological space, we have to really pay attention to certain technical skills. So skills like project management, database management. So if there's anyone that is interested in like SQL, learning how to program, so any kind of programming language, now would be the time for those that are interested in those kind of skills to actually start to pick up those skills, so that when states start to decide to deploy ICT in the healthcare space, you are well suited to move into that new phase of your profession. So, learning project management, learning data analysis. So, there are plenty of courses out there where you can learn Excel, right? So, Microsoft Excel is one of the premium tools for data analysis. So learning those skills and how to analyze data, healthcare really does generate tons and tons of data. And so having the skills to really navigate that data and actually pull true information, true clinical information out there that would be helpful to the organization. So analyzing that data and really even managing the data in the back end. So database management. A lot of the applications that e-health applications that will be deployed are based on data. So you have to input data to be able to get something out of it. And so having those skills to be able to troubleshoot, so running queries and running queries in the back end to make sure that the applications are running properly and you're getting good data out of that would be beneficial. And also knowing, so specific to healthcare now, knowing the different data exchanges that are out there. So we know that if anyone has been involved in mobile applications development, we're familiar with APIs. So again, for anyone who wants to move out of the typical roles of HIM, so not just records management, not just clinical coding, not just disease registry, but really trying to move into the technology space, it would be helpful to kind of get yourself familiar with the different data exchanges that are out there, because that's really what all of the electronic health records will be built on. So things, just knowing what API is, knowing the different kinds of healthcare data exchanges out there. And one last technical skill will be product management. So a product really is, let's just consider a mobile application. That is considered a product. To be able to actually deploy that application, there has to be a product manager attached to that project. So you need to learn how to actually work through the different stages of implementing the product. So you need to learn how users in the organization are going to be using your application. And then you need to learn how the different phases of design of that application. So product management is also another technical skill that that would be very beneficial. Beyond product management, though, I think that I really wanted to speak also on the point of workspace, your skills. So the skills that you have at work is just as important as the technical skills that you have. It is very easy through training. So through training, it is very easy to pick up project management. You know, you can register for a project management course and go through the exam and, you know, take the exam and you become certified. You can learn programming languages. You can, there, for any technical skill, there is education available for you to learn. But I think what is also very important, working in healthcare and really any industry, is the workspace skills and the soft skills that you have. So knowing how to collaborate, in healthcare, patients come first, right? We would hope that patients are the ultimate customers in healthcare, right? We want to make sure that their health health outcome is positive, but beyond those healthcare outcomes. And so, as HIM professionals, to make sure that patients are getting quality care delivered, we want to make sure that we're working with our colleagues, so being collaborative, knowing how to plan and organize, right? So just learning technical skills again is very important, but knowing how to plan and organize work, and problem solving and decision making is very, very important in technology. A lot of things can go wrong in technology. So, you come and you start using an application, but then you're not getting the right results. How to actually problem solve and make quick decisions that would not be harmful to patients also is very important, and really being innovative, right? So um, it is true that technology is helpful in many ways that we live our lives, but we also need to be very innovative in the way that we think through the way that we use technology. So being innovative and knowing how to really pick up technology really quickly, because again, I mentioned that WHO and just the whole COVID-19 pandemic has really caused fast-paced development, right? So I was just reading yesterday that they released new ICD-10 PCS codes. So knowing how to really pick up working with technological tools is very, very important. And I think last but not the list is having just customer support, right? So paying attention to our customers and making sure that we are, and the customer in this instance would be our patient, right? So a patient is the first and foremost, is really the foremost customer in a healthcare setting. So knowing that the work that we do as health information professionals is really helping the healthcare delivery down the line and making sure that our patients are receiving quality care. Um, Some of the healthcare ICT opportunity areas that I noted on my presentation here is I did mention project management already, and I mentioned that I am currently studying for my PMP. So you can, once you take that PMP exam, you can work as a project manager. You can work as a systems analyst. So if you have if there's a company that has deployed mobile health, you don't always have to be a coder or a programmer. You can work as a system analyst because you can look at the system and really analyze how it works. You can analyze workflow. If there's any kind of process that doesn't really work well for the organization, you can be the one to say, hey, I think we need to rethink this workflow process. So working as a project manager, working as a systems analyst, and working as an implementation consultant. So implementation consultant really is just the deployment of that application. And I mentioned that uh, a certification, PMP. There's also Lean Six Sigma that would be for process improvements. So those are really some of the ways that we can bridge the skills gap in HIM. So not just focusing on the traditional roles that we've always had, but just really kind of honing in on some of those project skills, product skills, and process improvements. I mentioned Excel earlier, so you can also work in data analysis. So working as a data integrity analyst, right? So making sure that all of the data, so for all of the data that our hospitals generate, we want to make sure that the data is accurate. And as an HIM professional, again, you are well suited to be able to analyze that data, know that it's correct, know that it's accurate, and that it would be helpful to the clinicians or to a disease registry that's asking for clinical data, right? That it would be helpful for them. So your job as a data analyst would be using, any kind of tools like Excel or any kind of business intelligence tool to pull the data out and make sense of it. Um, we can work as clinical content analysts. So that is something that is maybe closer to our traditional role. So a clinical content analyst is somebody that has knowledge of ICD-10. And if, let's say, there's a technology company that wants to deploy an application, they need to be able to have, all of the different diagnosis codes and procedure codes in their application. As HIM professionals, because we know what those are and how they work, we can work as clinical content analysts, reviewing the content that's being inputted in these mobile applications, making sure that the content is able to be mapped appropriately, and then just really helping with the development of the content of those applications. And we can also work as reporters. So reporting in HIM is very, very crucial, right? So anybody can come, government agencies can come and request reports and data around, what the population of patients that have a certain disease in the state. That's, as HIM professionals, we're able to go in and pull those reports, right? In the past, that could have been done manually on paper. Now, as we are moving really into a technology, just fully technical world, we are able to work as reporting analysts. So again, it will be very helpful to learn um, tools such as Excel. There's also tools for data visualization like Tableau. Those will help with, so it's not just pulling the data, but how do you actually present the data whereby it makes sense, it looks I don't want to say it looks pretty, but when you present data in a concise way with colors and highlights, whoever it is that is reviewing that data is actually able to review it more quickly, and they can use the data more efficiently. So learning how to use business intelligence tools and healthcare intelligence tools is also important. And I think I already mentioned SQL, so database management as well. Um, and I'm kind of wrapping up here. So some of the pathways to close the skills gap, I think in general, most of us have gone through a formal education training. So whether it is through a certification or a degree in health information management. So we will continue to use the path of formal education to bridge that gap. Also, we would consider internal skills training programs. So if at the hospitals that we work with, any organization that we work with, we would consider internal skills training programs. So that's basically for all of the skills, data. So the data skills that I mentioned, project management, all of those skills that I mentioned earlier, actually developing a training program internally for your staff and for anyone that you will be recruiting in the future will be very beneficial because that would not only be beneficial for you as an organization, but it really will help your current staff to know that you are interested in their professional development. So again, formal education, internal skills training program, and really just adopting technology, right? I find that a lot of people are taking online courses. So there's a lot of free online courses on websites such as Coursera, Udemy. There's a lot of free colleges that are offering free courses now. So really adopting technology and applying for those free courses. Some of them do charge a minimal fee, but if we are looking to bridge the skills gap to enhance our skills, then I think that it would be a beneficial effort to um, enroll in online courses to kind of enhance those skills. And then my last point here is really building relationships with professional organizations, right? Just any kind of international organization that is related to the health information management program, just building a relationship with them, cultivating that relationship so that anyone who is interested in working with the field will have access to resources that will help them and really just keeping that would also allow us to keep up to date with anything that's happening globally in the health information management space. Um, so having said that, some of my takeaways is really to uh, pay attention to our current core functions, right? So again, records management, diagnosis, coding, data management, those are all things that we do today. Those are all functions that we perform today. Those functions are still very important. They're never going to go away. In as much as we're trying to move into a technology era, technology is only going to allow us to do those things more efficiently, but those functions are not going to go away. So we need to pay attention to those core functions, but we also need to embrace the information technology era. We need to embrace the data era. And so knowing how to capture data, manage the data, all of that is the future of the industry. That's where we're moving. It's almost inevitable, right? So that is the future. And I think that if we want to remain in the industry, remain in the HIM field, and most importantly, to be relevant in the field, then we need to embrace the technology and the data wave. And just a last point is to be a leader, right? So a lot of complex changes are happening in healthcare. It's a really, really exciting time in healthcare and in HIM. A lot of complex changes are happening. Sometimes that can create limitations, whereby there's a lot of challenges. You're having to work with different kinds of organizations, different alignments in the healthcare field. That can create limitations, but it also can create exciting opportunities. So just really being a leader, and really going and pursuing knowledge continuously, constantly is would be a way to make sure that the skills are being refreshed and we're remaining relevant to our profession. And that's the end of my presentation.
Thank you very much, Ma. Really enjoyed that. That's a lot in a very brief form. Thank you very much. Really appreciate that. So I have some questions in the chat section. Want to know what's the difference between a clinical content analyst and a clinical coder? A clinical content analyst, like you just said, and a clinical coder. What's the difference? So we'd like to find out.
Sure. Yeah. So the clinical coder would be the person that is working in in the hospital organization. You will find most clinical coders are working directly for an hospital organization, right? So they're the ones that the clinical coder would be the one that is taking that patient's record, who is reading the doctor's documentation, and who is applying those diagnosis codes to the patient records, right? So that they can send it for reimbursement and billing. The clinical content analyst is the person who is reviewing that person is actually working with technology. So that person will be working with a technology company that is maybe developing an EHR, and that person would be the one that is familiar with ICD-9, ICD-10, ICD-10 PCS codes, and that person would be working from a technology standpoint. So at this time, they wouldn't be working with a patient record, but rather they would be reviewing those codes and how those codes would be used to develop applications or used to be developed EHR. So clinical coder is working directly with patient records at a hospital, and a clinical content analyst will be working with most likely working with a technology company.
Okay. Well said. Thank you very much for the response. I believe
All
the
right.
um okay, Dr. Falasha, are you back now? I think
Thank you. Thank you. I'm back.
beautiful.
I'm back. Thank you. All right. I want to say a big thank you to Ms. Ibijoke Amano. You have really done justice to the topic. And well, if you ask me, it's like we should continue with that discussion maybe for another 30 minutes. But I understand the time is limited and you have to attend to some other things. Well, the channel still remains open for questioning. At least we still have about 4 minutes for Ms. Ibijoke to uh,
Yes.
leave us. And well, if we still have some other questions coming in, like I have a question here about this is much of a Nigerian situation question, talking about medical directors and hospital administrators who are not paying attention to the new normal, talking about digitalization of healthcare. And so, how do we handle that? I believe that is dealing with not being responsive to change. Maybe a word of advice from you, Ibijoke.
Yeah, so you will be surprised that it's actually not just a Nigerian thing. When we started to implement health records here in the US, way back, I think there was a push for EHRs way back in 2009. There were a lot of doctors and administrators that basically just retired. They did not want to be involved in any kind of technology. They were not, they just retired. They were not interested in that change. So it's really a global issue. And to your point, it speaks to general resistance to change. They generally do not like anything to come in and disrupt how they are working. So for medical directors, hospital administrators, I think that what I found over the years in my consulting career is that you have to be able to show them value. What is the value add to what you are presenting to them, right? So how is this going to, one, make our lives better? And how is this going to, and if you're talking to medical directors, right, how is this actually going to benefit the patient? So it's a lot of hard work to actually put that value add statement together or value add presentation together, because that's really what you need to be able to present to them to convince them that this is not just about we're coming in and we're having you click buttons and use computers. We're not interested. No, this is really about improving processes. There's a lot of broken down processes, right? So one needs to to figure out a way. It's hard work. So, and I think that just showing them, I'm sure that there may be some organizations that are more receptive to change. It may be a matter of showing them the benefits of that change, right? Finding an organization that has adopted technology and showing them what the benefits has been for that organization, or even coming up with scenarios, come up with several different scenarios and presenting it to them and showing them what that value would be. The onus is on us as HIM professionals, as technology practitioners, to show them what the value would be. And there's plenty ways that we can show them. So I think the bottom line is just showing them what the value would be. It does take time though. There are organizations that we work with, that I've worked with in the past, that we go and we implement technology. When we return back to them 6 months later, they're not using the technology the way that we have recommended. So we have to kind of remind them or keep kind of working with them. So it takes time. It's not going to happen overnight. One has to be patient, and just really, we have to maybe think about working with, because the push that happened here in the US was supported by the government. So the government was able to provide incentives for them to use technology. Now, I know that may be a tricky thing in Nigeria sometimes, but also maybe getting support from other organizations um, for those that are being resistant.
Thank you very much. I believe the points are well taken, and those of us back in our various countries will begin to work on that. And the last area are trying to make sure the government is involved so that the policy direction will make it to be possible. So thank you very much, Ibijoke. You have really, really done and gone beyond the expectations. And I believe everyone who is on now is happy and will know that the future is even brighter for everyone, especially in the health information management profession. So, well, if you are still with us, we hope you chip in one or few things when we come to the general questioning segment. So thank you once again. God bless you. We so much appreciate you.
Thank you so much for your time.
All right.
I appreciate it.
Yeah. So, ladies and gentlemen, we are moving on because we are strictly following our time schedule. And without wasting time, I will want to hand over the control to Dr. Uda Eldosugi. She will be talking to us on, the banner topic for this webinar, talking about the global socioeconomic impact of COVID-19 pandemic and how it has affected, or how it's affecting, access to healthcare in low and middle income countries. And she will also go further to identify the challenges and prospects of telehealth and telemedicine application in countries that are categorized as low and middle income countries. So, Dr. Eldosugi, you are welcome. You can take over from this point. Thank you.
Hello, thank you for having me. Am I able to share my screen?
Yes, you can.
Okay. It just says host disabled, participant sharing. I think you have to admit me to share my screen, if that's okay.
Yeah, screen sharing is available, ma'am.
So it's telling me that I need the host disabled the participant screen sharing.
Okay.
Yeah.
In the admin, we have to allow the screen sharing to be possible.
Okay. Okay, so I think, here we go. All right. So I hope to be able to speak to you today about the socioeconomic impact of COVID around the world, and more importantly, upon us in low and mid-income countries. And then the challenges, the barriers, and enablers of telehealth and what it would look like if we went ahead with telehealth. So I wanted to start by sharing a bunch of photos basically about the apocalyptic fallout. And I call it apocalyptic because it really felt like a movie. It just felt everything was closing down. The streets were silent, and we're not used to that in New York. Everything is buzzing 24/7. And to see this complete lockdown closed was very scary. It really did look like a movie. And then of course, people started working from home, and we could see Zoom picking up on the stock market, and people trying to work with their kids intact. So it was a very difficult time, and still is, obviously. 5 months later, we all thought going into this that it would only be 2 weeks. Then all the flights were canceled. And I bring all this up because all of this is what caused the effect, obviously, on the economy, because there were no people going out and spending. So the traffic flow for the money was coming to a halt, and we saw quite an abrupt crash in the market. And of course it was worldwide. I think initially when it started in China, we thought that was very far from us, and it just was so surreal to when it hit home and we got to see it for what it is. It was really a difficult time. And then, of course, throughout globally, all the healthcare systems started getting, oversaturated. Really, they were overwhelmed. There was this global shock, and we could feel it all around. That a lot of things were just unbelievable. And this photo with the dead bodies in New York and trying to help with the PPE, and I want to explain this because I think in Africa. I am originally from Sudan, and I worked a lot with our Sudanese Ministry of Health, trying to, collect donations and work with them to figure out what we need and how to go about getting PPE. But I was also working with the office of the mayor in New York, Mayor de Blasio, trying to get PPE for New York as well. And it was just as tough. We didn't have test kits. The masks weren't coming in. The whole world was fighting over the, procurement, and the supply chain came to a halt. So everybody was overwhelmed. And what the point I'm trying to make is there's no healthcare system in the world that was designed to take on the shock that occurred. So it's not just for low-income countries, it's everywhere. And these photos are, New York, India, and Ecuador. Look at that. And everybody, it was sad all over, basically. A very grim outlook. And like I said, a global disruption of the supply chain. And we heard a lot of stories about different countries trying to get to the port and basically just pay cash and take up the quantities available. And that is really what caused a lot of disruption globally. But, I think just as we look at the downside, we need to also look at the bright side. What could we do? I always believe in every situation, we need to look at it both ways. If it's going sour, let's think of how can we next time at least learn the lesson. And for next time, we don't want to repeat what's gone and happened. And so what do we do next time? How do we set up our supply chains going forward so we don't get back on this wheel again? So, and below here, these circles, just to do a root cause analysis of where the supply chain went wrong for us. For every country has to figure out for itself what happened, obviously. And then perhaps if we did have, digital solutions in place, they would help us remain intact in terms of trying to identify where the problem is and how to fix it going forward, and hopefully define the segments and prioritize and do some iterative analytics and predictive modeling and change and crisis management in the future. So I wanted to really look at what is the situation currently. So this chart is directly from the WHO website, and it goes up from February down to August, which is last week, just to show what's going on. And the numbers are scary. They're still scary. There's about 10 million in the Americas. And I put a little chart here to show the United States of America. So half of this amount is from the United States. It's definitely the country leading the pack. And it's not a good place to be leading in this situation. So it's not always good to be the leader. But basically it just goes to show. And from mid-March, when we weren't thinking this is going to happen to us, we were running around trying to find toilet paper. And then in April is when it hit home, and we started to see the cases. And then it hasn't stopped since. So the amount is accumulating. So Africa is down here at 900, so a little less than 1 million. Even though when we look at the population, Africa is quite populated, but the incidents are actually not as high as Europe and the Americas or Asia. So there's some comfort in knowing that. Then when we look at the deaths, the amount of people dying from this COVID and the pandemic, and we see that 2 weeks into April, there's a bit of a spike right there. And I think that's the real shock of when gone oversaturated. That's when they had trucks outside piling up the bodies, and it was just a nightmare to watch. And there's even a spike in the Western Pacific right here. And you could see this is Europe. So everybody spiked at this point. I guess that's when everybody got saturated together. I'm not sure. I would have to look at a little bit more of the details, but we have just a few more spikes, and they tend to look like just a one-day thing. So I'd like to know what the local events were that caused the spike. Once again, 162,000 for the United States. So a little less than half the deaths were in the United States. So perhaps we were leading in the numbers, but in terms of deaths, just a little less than half. And if you go on the website from the WHO, you can actually see that per country, per region, break it down into days. So it's quite interesting. So I wanted to really see, okay, we talked about the incident, the amount of COVID going on and the number of deaths, and then how the healthcare systems were able to tackle the situation. And this is why I wanted to highlight this part in the fact that the high-income countries or the low-income countries, when this pandemic hit, everybody is affected globally. But what could we do in order to prepare? And I would say having an efficiency in our healthcare system, obviously. And that's by, you don't necessarily have to spend a lot. That's the issue that's the point that I'm trying to make. The message to take home is it's not how much we spend on our healthcare system per se, but how we use it, where is it being utilized, and how are the resources being allocated. And so just a good example of this, and this is pre-COVID, so these charts are pre-COVID, but the percent per capita or GDP expenditure in healthcare, when you look at Equatorial Guinea and Croatia, we're roughly spending the same, about $1,200, $1,100, roughly the same amount of money going into the healthcare system. Yet when we look at the outcomes, which is the real measurement of how a healthcare is performing, a healthcare system is performing, we see that Equatorial Guinea is very high with infant mortality and very low with life expectancy. Compared to Croatia, look at the big difference. Excuse me? Okay. I also wanted to compare Sudan with India. So even though we're spending roughly the same amount of money, and we only have about 40 million people in our population census in Sudan. I think Nigeria is about almost 200 million, if I'm correct in saying that. But we don't have a lot of people. We're spending roughly the same, but look at our infant mortality is really, really high compared to India, and a little bit shorter in the lifespan. So we're not very efficient, is what this is saying to me. And this is where we could go in and fix the healthcare before, before crying for help and asking for money. Because I just believe, let's fix what we have, manage our resources and our human resource, like Ms. Amona was saying just a little bit ago. And I love the presentation. It really covered what you could do with the workforce and how that could contribute to the healthcare system. So then I wanted to show you or share this slide, and this is straight from the OECD. The website is down here, and it just goes to show when you look at the regions according to the World Bank, low income, mid income, and upper mid income countries, and you look at how we're spending money and where it's going and what's coming in terms of funding. So when you look at this blue, the amount of blue is your official development funding or financing. And so this is quite high with the low income, and it goes lower as you get into the higher income countries. Once again, when you look at the regions, Europe obviously is not low income, but Central Asia brings this up. Here we've got the Middle East, North Africa puts it up, and then Sub-Saharan. When we're looking at remittance, which is the amount of money that we're sending home, folks like myself who live outside the continent but want to send money home, and this is why the block of green is really much bigger than in the higher income countries. Portfolio investment, this is more like, this is the real foreign investor coming into your country and putting in money. And it's really low with low income countries versus with the higher income countries. Everybody wants to invest where there's already wealth. And when we look at it here, once again, it goes much higher with the Middle East and North Africa. And I'm guessing most of this is the Middle East, and Sub-Saharan Africa is doing well. So that's a good sign. But these gray little diamonds are your domestic tax revenue. And so we see with the low income countries, it's quite low versus the high income. Look at how high this is. And what that really means is the amount of tax collected per GDP, per percent GDP. That's the amount of money the government is making from its, all the financial resources, and it's being able to control it because it's able to track it and tax it. And what that does is, of course, give the government enough money to have so that it is a rich country and it is a high income country or upper mid-income country. And that is really a measure of how much control they have over their economic resources. That's why this is relevant. When we look at the regions, once again, it goes a little bit down when you have North Africa included, and very down with the Sub-Saharan Africa. So these are just indicators, just like we have healthcare indicators, and they help us figure out what we're trying to do. So this is another good chart that compares what we have today currently with COVID compared to the financial crisis in 2008. Once again, remittance back then, and also the FDI, which is the Financial Development Investment. The gray line below the zero is where we are today, the COVID. So with everything, it is lower with COVID, except with the portfolio investment. So I guess people were not investing. There wasn't financial traffic, so to speak. People weren't going out and investing. Businesses shut down. Everything was on hold. And when we look at remittance, Financial Development Index, portfolio investment, once again, in 2008 is much higher, and then other investments in this sector. And just wanted to read you here because you have domestic spending going down. Where did I put it? I just wanted to read some of that for you because, so we have domestic and external financing falling short of our sustainable development goals. So this was already taking place even before COVID hit. We weren't able to reach the targets that we had for sustainable development goals. And then comes the reduction in domestic spending in terms of, with COVID. And what this has done is lower the corporate profits and decline the consumption internally. And of course, that reduces the taxes being collected by the countries, the high income countries. And how that reflects on us is all a dominoes effect, because they don't have enough money collected from their taxes, they're not spending on international trade. And what is international trade? Essentially and eventually, it's them buying the natural resources from us, which we are so dependent on. And so it does come back to haunt us. This whole COVID situation has, reflected on us negatively in that our resources are not being bought. And that's why we have less money coming in for the low-income countries eventually. So I wanted to also take time to look at challenges for us. What are the barriers for us being developed and moving forward? So we have more than one issue. It's not just the challenges in terms of the telehealth or digital health. It's the challenges and barriers in terms of our healthcare system altogether. Let me switch back to this. So I think in general, low-income countries, and maybe when I say low-income, I'm obviously thinking of Sudan, but also Sudan is a representative of Africa, really, and most low-income countries. So inadequate infrastructure. We've got issues with the infrastructure, which we may blame money for that. But we also have issues with organizational structure, which these are some things we can work on. And that's where we really want to know what the challenges are, what are the barriers, so we can go and fix them. We need to be able to identify what the challenges are, not wait for someone else to point them out. And also not be in denial and not overlook them for any reason. And that's why we really need evidence-based information so that we can actually understand where we're really coming from. And we need those qualified healthcare workforce that Ms. Amona was speaking about. So the organizational structure, this entails, not just the culture in the organization, but the management and the resources, what we do with it. There's a whole bunch that goes into it. Also the ratio of clinicians to the population. For example, so that this is a major, obviously major metric for healthcare. We have a very low number of clinicians that remain in the country. We have a lot of brain drain. They migrate to other countries seeking a better quality of life, and we end up with a very low number of clinicians, and they all want to stay in the city, which becomes very densely populated in the urban areas, and then the rural areas are completely depleted and barely have any clinical professionals. So we need a lot of, so I'm trying to talk through this so we can all get a better insight into the dynamics, at least in Sudan. So I don't know if this is also the same in Nigeria, so please let me know afterwards. So then we need workforce management and training and CME and all the rest of it. Access and equity. Healthcare is not accessible everywhere, like I just mentioned. For example, in Sudan, we have 70% of our healthcare is in the capital versus the other 17 states. We have 18 states altogether, and the capital takes 70%. So everybody has to come in and travel 3 to 5 days to 7 days just to get some healthcare or clinical attention. And so that's not very efficient. The quality, once you get there, is also not that great. And so cost effectiveness is not doing well. Supply chain management is not doing well because we run out of medication. We don't know what we have. And I mention all these issues because these are all digital solutions. So as we identify the problems that we have, every problem can have a digital solution. It may or may not, but it can. And it's folks that are, as Amona mentioned, people who are certified or trained in health IT who can identify where you can put in a software or any digital solution. And yes, in the long run, we could see the cost of these things is going to give us that return on investment. So they're not immediately seen. And I'll come to that later on and speak more about it. We have a lot of medical tourism, people seeking medical attention outside the country because there's no trust in the quality of care given domestically. Because we have misdiagnosis, a lot of medical error, and it's not even being documented. We have a big issue with documentation. We also have our healthcare system has competing health system priorities. So a lot of the healthcare needs, because there's no realization of the value of digital health and documentation and analytics, we have a lot of folks misappropriating funds into other things, like they want extra beds or they want medication instead of computers. Computers aren't going to treat us from conditions. Well, yes, they might. We've just seen that with COVID. Then we also have inappropriate utilization of the different tiers of healthcare. So primary care versus secondary and tertiary care. So for low-income countries like ours and like most of Africa, we have a younger population in general, 15 to 60 years old versus the elderly. People aren't really aging. And it's, once again, it goes back to that lower expectancy, life expectancy or lifespan. And what that does is, your population is younger, they're not aging and older. So you really need to focus on primary care and preventive care because that's your workforce that you need to keep healthy. So there's a lot of reasons why we want to look at where the utilization of healthcare is taking place. And we need numbers for this. We need real world evidence and statistics. Poor planning and preparedness for crisis management. I think in Sudan, we shut the airport really quickly when COVID was about to hit, but I think there was a lot of skepticism. Folks were saying because it's so hot, the high temperatures are going to kill the virus, we're not going to get COVID, and everybody was happy. And I was just panicking because I'm thinking, you just haven't had the traffic come to you from China. Travelers from China went to Europe and the Americas, and that's why it hit here first. And you could see the wave when the pandemic started. And then eventually, by the time it got to Sudan, we should have had enough time. We should have been prepared. Everything should have been in place. But all the skepticism prevented us. Being in denial, like I said earlier, prevented us from preparing. So we need to be realistic. We also have incohesive and fragmented data that is not standardized. So there's a lot of variability in the data as you collect it and the data sources. In Sudan, at least, I think Nigeria and other countries are doing better than Sudan. Inadequate and incomplete documentation and the storage of information. Storage is important because you don't want everybody to have access and be able to edit the information. So we don't have complete documentation. And when you look back in the pipeline of clinicians, they're not being trained well enough to have and produce adequate information documentation. So that's an issue. And that's why I said we need to look at every problem and get to the root cause of where it's coming from so we can go back and fix it. And not everything needs money. Just like I said, we have 57 medical academies in the country, and only 2 of them certified internationally. So that's a really big issue. It's just unacceptable. Value recognition for data, for information, for knowledge. So you begin with just your regular vital statistics, how many people died, how many were born, and then it becomes information as to, what were the causes of the death. This is your mortality. And then it becomes knowledge. And, you process the data until it becomes a database, a data set that you could eventually analyze and have information from and make use of it in secondary use of data. But we got to start somewhere, and that's why I say this. It looks insignificant, but this is where value recognition comes in. We need to understand the value of the information, start having registries, and throughout Africa, not just Sudan, because I think we also have, we've got a way ahead to get to the point of data curation before other people come for it, just like they came for our natural resources. I don't want to sit and watch everybody come for our data. So we don't want to just go and start collecting data and then give it away. We need to have data ownership, and we need to be able to control it and have limited access. According, there's a lot of issues, security, privacy, and all the rest of it. So We cannot have a disconnected research and development. Our healthcare needs to align with the clinical practice. And what I've seen in, for instance, Karolinska Hospital in Stockholm, I was there last year. I worked with the NHS in Scotland for a little bit, and all these up-to-date and digitally mature medical facilities really tend to bring research onto the grounds with clinical practice. And that's where we could also improve a lot, because we can have our clinicians come to practice, share best practice, learn from each other, find the problems, find the solutions. So research and development shouldn't be sitting on a shelf, dusting away, which is what is happening in Sudan. It needs to come forward and on the ground with clinical practice. And then financial models, revenue cycles, Amona mentioned, allocating funds. And of course, we have a big issue with corruption now. It's just getting worse. And so there's a lot of change management that is required, and you need to prepare for every transition or transformation. So we're talking pre-COVID, post-COVID, crisis management. What's going to happen now? How are we going to get digital? All of this needs management, and we need to, pay attention to it. And having digitization, of course, gives us transparency and accountability, but also sustainability, because we're able to iteratively analyze and see where the issues are and fix them, hopefully. And then, of course, scalability, because I think Yaya a few weeks ago was speaking about Africa having a lot of pilot projects for digital health that are not scalable. And I think they're not sustainable or scalable because of the revenue cycle issue. We really need to integrate our healthcare systems. That's another issue. And of course, include environmental health, including waste management. That's a big issue in Sudan. I'm not sure about the rest of Africa. I've seen cleaner cities on Khartoum. But environmental health is an issue, in terms of cooking indoors versus outdoors. I think that's big in India. So in low-income countries, these are the general challenges in healthcare. When we look at challenges in digital health, and I say digital health just because that's more comprehensive, it's a broader umbrella, and it includes your telemedicine and telehealth. And once again, telemedicine, telehealth. Telemedicine is strictly medicine with a telephone. That's the easiest way to think of it. So it's not a telephone. It could be audio only. It could be video. And it could be text. So there's different formats, but it's medicine versus health. Health is more inclusive, because you can use, instead of just the physician, you may have the nurses, physician assistants, or just medical assistants, or even midwives. Any amount of training clinically is allowed to help out with telehealth. And telehealth could just simply be health education. You mentioned education a little bit ago. And continued medical education is an issue, the research and development aspect. So telehealth is just more comprehensive and a broader umbrella. So poor health systems and healthcare integration is an issue when it comes to digital health. I think I spoke with Dr. Raphael in terms of having different software systems in the different medical facilities is still not integration. So you need the interoperability. You need the different medical facilities to communicate and be able to pass information back and forth. And this is not just low-income countries. Definitely all the major high-income countries went through this. They started out much further than us. They started out in the 70s keeping computers in hospitals, and they started out keeping them for billing and for administrative tasks, but eventually they got into the clinical data. And when they did this, the hospital started, every hospital is an organization. It's like a company. And so they get their own software and start using it. And so eventually they got to see they weren't connecting, and they needed to go out of their way and restructure everything so that they can communicate with APIs. So interoperability and integration is crucial. Competing health system priorities. Again, instead of telehealth, people are using funds for allocating them towards medication and fighting PPEs and fighting COVID. The lack of national framework or roadmap for e-health. I see a lot of countries, because there's no leadership for the telehealth, and so the medical facilities popping up with different software instead of actually having a national roadmap whereby the policymaker or the Federal Ministry of Health, so to speak, will have an actual plan and then a strategy, and then help align everybody, give direction, give them toolkits and things like this. Well, now the international health community provides a lot of toolkits free, and there's a lot of open source material that we could use as well. Organizational structure and value recognition of digital health in a system. So once again, organizational structure, cultural competence, there's a lot of issues that prevent us from having digital health. In our country, in Sudan, and I'm guessing a lot of Africa, will have issues with internet, people getting cut off or slow internet. We also have power outages. We still don't have electricity in some areas, in rural areas that can't access healthcare. So it's poor infrastructure. And like I mentioned earlier, regulation for e-health needs to come from the top down, a legal framework with privacy, security, data use, and then of course the HIPAA guidelines. And I think now in Sudan we have some ICT laws, but there's no awareness of HIPAA, which is your Health Information Portability Act. And that was in 1996. I think Europe just released one in 2016. They released their own laws, but I'm hoping that at least for now, I think the easiest thing to do is just adopt the HIPAA, and that way you're safe because you have everything compliant with HIPAA. That means, am I taking too long? I'll try to rush. I'm sorry, I hear some noise. Standardization to reduce data variability. Once again, different sources give you different data, and we need to have standardized methods and coding. Perhaps if we use the ICD-10, and you know, coding is a whole degree. It's a lot of work. It's not easy, but there's a reason for that, and that's the reason that we need standardized data. International coding for diagnostics, like I just said. Health IT experts, so the healthcare workforce needs to be trained. We're dependent on a lot of international assistance, technically and financially, and we need to just look at that. There's fear of technology and resistance to change. A lot of it, the underlying reason for the resistance is the fear of technology. For example, in Sudan, a lot of the consultants are older in age and therefore not tech savvy. And I think the good thing about this is, obviously the younger population means we have a lot of young folks on Facebook and other technologies that are able to pick up technology. But we need to use this in the healthcare, not just social media. Perception of the high cost, that it's going to cost a lot of money. So maybe some software, but we could produce locally. And like I said, there's a lot of open source that could be used. And also telemedicine or telehealth in particular is not expensive. It's simply any tool for a video conferencing. And having said that, not all of them are HIPAA compliant. I know Zoom is actually HIPAA certified. There's something called Ring Central. It's a little bit higher level of Zoom, the same makers, and that is HIPAA compliant, but not, for example, FaceTime is not HIPAA compliant. And so, there's different ones, but I know now in the US, we've had a lot of leniency in terms of regulations so that people are able to, during COVID, deal with the situation. So it's not always a high cost. We need to think about what's going on. The perception of lack of demand, like that there's no demand for it, well, that was pre-COVID. I think COVID set that free. We now know there's high demand for digital health and that people can just stay home and get seen and have access to healthcare and manage their chronic illnesses and even preventive and primary care. Like I said, once again, business models, revenue cycles, we need to look at those because those are the main barriers for sustainability and scalability. And then an over-reliance on funding from external sources, the lack of evidence-based strategies, the whole concept of having evidence for all our strategies and so that we are more realistic and aligning that nationally and then looking at patient outcomes. So what does telehealth eventually look like? So there's another method to gauge how mature your digital health is. And it's not just about the infrastructure. So you can have the components, the technical know-how, the technical components, and build the software and the infrastructure, but not use it. So if you're not using it, which is a pre-COVID issue, you know, there's no point. Why do you have the technology if you're not going to use it? Whether it's the physician or the hospital or the patient, like we have the patient portal. And so that wasn't being adopted. It was regulated, it was incentivized, and a lot of health systems bought patient portals, they put them out, they made you go sign up for them, but patients weren't really using them. So we had maybe 95% adoption, but not utilization. So they sat at 15% up until the end of 2018. It was only 15% of patients using patient portals to access their medical records and to book appointments with their physicians. And so there was no point in having them if you're not going to use them. So that's not digital maturity. You need to go back and educate people and raise awareness. And this needs to go in parallel to installing software. And when they looked at this, they came back and they said, well, hold on here, people aren't using it. We got to do something about it. So digital maturity is a method to gauge your readiness and utilization for the technology. So I wanted to show this, and this has become, I'm not sure where this came from. So these lines is what I'm not sure where they came from, but the photo is about 4 years ago when I was speaking to a friend of mine who's a physician who was kind of busy, didn't get back to me. I got frustrated. I'm like, I'm on the phone, talk to me. So, you know, my friend sent me this photo and I'm like, what is this? And they said to me, this is a medical facility in Sudan. They were treating a patient right there on this bench. This brick was the pillow, that's the IV, and that was the environment they were in. And, you know, that patient felt better because they got their IV and they went home happy. So, you know, one way to look at it is they were happy. They got healthcare, but, you know, is this what we want? And so I was not frustrated anymore. I was really sad and I cried when I saw this. But, you know, what do we do about this? At the time when I spoke about telehealth, because that patient need not come to this environment. They could stay home and get the treatment they need. So that's where telehealth can help you. And, you know, obviously not with the IV, but that's another issue. That's, there's wearables, there's monitoring, remote monitoring devices. There's services now that provide these consumables to you at home, even when you want to test for labs, diagnostics, radiology, all of it can come to you instead of you having to go. This is big in India now. So basically, I'm just trying to share the situation with medical facilities in Sudan could be this bad. And this is where our health information system is at. When if the same standard, the same level, this is how bad it is. And I do that because this is the next photo that I want to share. And this is also in Sudan. This is 6 miles away. This is a medical facility in the same country, 6 miles away. And this is the breast cancer center. And obviously this shows that, yes, we could do this. We could have this high standard of care and this, you know, excellent facility, and we could get digitized. So there's hope, there's potential, and there's hope. But this also shows the lack of equity in healthcare, the disparities that you can have these two conditions or medical facilities exist within 6 miles of each other. And, you know, the government isn't looking at this and thinking, okay, what could we do about it? So what does telehealth look like? And, you know, what do we want to do with it? So I wanted to just point out this one, the COVID screening, is where it's really being used now and it's taken off. And, you know, as bad as COVID is, it's helped a lot with digital health. This is another way of looking at it. These kiosks could be set up anywhere, but this is at home care where, you know, obviously you're a physician and this is for your elderly at home. But mainly, obviously for telehealth, we could use it for rural villages, but schools in Sudan are a big deal that we could use because essentially that's where kids show up every day. So if you have one nurse with one computer, you could do a lot of primary care in the schools. Correctional facilities, when you don't want to take the inmates out, maybe the doctors don't even want to see them, but or if they have mental health issues, they could use telemedicine, and this is all it takes. And anybody anywhere could actually get to see them. And what telemedicine or telehealth really does is give the physician or the provider a lot more time in their hand to be able to see more patients. And it gives more access to more patients, exponentially so. So it's really a no-brainer. And I just look back now and think, okay, where were we before COVID and now? Even in the ambulance and in surgery, intensive care, even in the emergency room. So these are all the benefits of what telehealth could do for you. And we really need to look at it in terms of stakeholders, because these are the guys that need to be engaged when you begin to introduce a digital health solution or just your telehealth. You need to look at the policymakers, the government agencies like the federal ministry, and what benefits they could have, and basically explain all this to them and show them, okay, guys, here's what you could do with this. You're going to have universal coverage, equity in healthcare, analytics, and all the rest of it. I don't want to read the details because I think I'm running out of time, but with healthcare providers, the same thing. And then for procurement efforts, we have a big issue with this, but this is another digital solution, CRM or ERP. Basically, there's a lot of software you could use for inventory, for quota, and for distribution of things. But it also, what this does essentially is basically give you a lot of transparency and accountability for all these stakeholders. But it also allows all these stakeholders to work together, collaborate, coordinate, and also to have a responsive healthcare system. Well, what does that mean? It means when there's a COVID happening, the government can respond to it, and either like they're doing now in the US, allow for a lot more regulations to be overlooked so that things can happen for crisis, or for healthcare providers to start speaking with the policymakers to tell them, you know, open this up, give us access, do this and that, or talk to procurement to get more supplies. And then for health insurance companies, and whether it's out of pocket like Sudan, or with health government health insurance. Either way, you get a lot more information for your buck. And basically, I think I can share these slides, but you can go through the details to see where telehealth can benefit. And you know, all of this needs to be paid for somehow. And like I said, revenue cycles are important. And nowadays, just like with research, there are trends with financial models. The trend is your public-private partnership. This is the digital health framework that I must have done this somehow. It's on my computer, I guess. I apologize. These streets, but so a toolkit, you know, this is mainly to show, to have a framework or roadmap. When you look at it, here's your umbrella, your governance, so your regulations and their standards, and then your the dynamics. Where do these come from? Who are the players, the stakeholders? And the stakeholders need to be involved, like I said, engaged for early buy-in from the beginning of the journey of digitizing anything. So pre-COVID, you couldn't convince physicians to use telehealth. But today, of course, we've overcome that situation now. So I think, you know, the importance of this webinar, I think, is to really reflect on, obviously, post-COVID, what are we going to do? Well, you know what? COVID did it for us. It's explained to everybody playing this game what is going on. How could we benefit from digital health? All we got to do now is let's go ahead and have a roadmap and try to build different digital solutions and move forward, really. This is the infrastructure. We could go through this. I could spend a whole hour on that slide. Then pathways for health information. And this really just shows the pathway of for information as it goes. These are the different so let's say your discharge summary, once a patient is dismissed from hospital and they're going home and they've got the information. So this is where the data is going, and all this is your secondary data. And you could use this essentially to come back and do some quality control or quality analysis, and tell this hospital people are staying too long, length of stay in the hospital, or they're discharged too soon without enough notes. They don't know what to do when they go home. And so, you know, you're able to track and see what's going on, but this is essentially, these are the situations that we need to look at and see how the system is performing And telehealth allows for that because it allows all these people to input information and then all these outlets. Sorry, I don't know where to put this. So prospects for telehealth. In terms of governance, you have your digital transformation, of course. Telehealth is going to help integrate the system, of course. Major hospitals and diagnostic centers will be connected on a national network, for example, or just on a local health system. So all these are different benefits that we can have, but I want to mention that we need to have a sustainability plan via revenue cycle or capacity building and training, but also a steering committee in every step, in every project, because you need somebody overlooking what the work is and not just the actual project planner and a geek squad. So this is in the US today, what we've seen post-COVID. We've seen that 11 to 76%, this was a survey done by McKinsey, which are an AI or a business intelligence company. And the survey showed that 76% of patients were comfortable using telehealth now. Remember what I said earlier, they had patient portals pre-COVID, and only 15% by the end of 2018 and early 2019, only 15% of people were using all the equipment that got installed, and now 76% are using. So that's this is something to look up to. And what could we do in Africa? We could do the same thing, and I think we will. I think we have more mobiles than actual desktops because of in rural areas, especially, at least in Sudan is the case. Providers were able to see 50 to 170 times more visits with patients because they're not waiting for patients to come in and out. It's a computer. They sit and they do their work, and documentation remains the same whether you're having an in-person visit with the patient or a telehealth visit. The physician is still using his Epic or whatever software they're using, and they're inputting the same information. So it's saving time by having patients be seen on a computer. And I want to just point out the primary care is more important for low-income countries than it is for high-income countries. Even in the US, we don't have as much primary care as we'd like, actually. And we have a lot of uninsured folks. Matter of fact, we have 50 million uninsured. We've, since dismantling the Obamacare, a lot of people have been found ineligible for health insurance coverage and therefore don't have coverage. And the people that are not covered tend to have worse health behaviors and tend to use hospitals as their usual source of telehealth. You could reach them, you can have this access. And then policymakers, 80 more services were allowed from Medicaid, Medicare, and government insurance agencies or entities. And this is because this is how you can have a responsive health system. When there's a crisis, people need to get more flexible, so they allow management of the crisis, but more people were allowed to be seen by telehealth. Initially in the United States, physicians weren't able to practice out of state. So if you move from New Jersey to New York, you may need, usually it's not that close, like if you move out west or Kansas or something, you kind of get lost. So your information doesn't move with you, that sort of thing. And the physician isn't able to practice on you the same because they're not licensed out of state. So now they've let go of this, and you're able to see patients out of state, across state lines, and many different services were allowed to happen and be paid for, because they also sent out different coding for telehealth so that people could get reimbursed. And that was a big deal. Okay, let me just say that, because this was a barrier in telehealth. A lot of people. Should I wrap it up? Hello? Let me wrap it up. These are plans for short-term and long-term planning for digital health, the archetype and what to look for. But this is really digital health, not telehealth. Telehealth is much easier, like I said. Reasons for implementation failure. If you don't have leadership support, inadequate resources, unrealistic expectations, resistance to change, poor planning, inappropriate revenue cycle, inadequate training, or poor communication. This is a Gantt chart for project charter, basically, if you need, and this is your training. If you have, like we have in Sudan, if you need capacity building, I would say the first phase of it would be training everybody in the workforce. The second phase is incentivizing and inspecting to make sure they're using it, and then finally penalizing if they're not using it. And then raising awareness, make sure that there's some amount of marketing being done for the service. If you're doing telehealth or any amount of digital health, you need to raise awareness amongst the public, but also the clinicians using the service, and use different methods, formats to get to people. This is a quick look at how the United States is divided up regionally, geographically, demographically, you name it. These are different regions. They have different health systems. They have different telehealth capabilities. And I show that because when you break things down into segments like this, it makes it easier to comprehend and manage. And that's what I think we should be doing with Africa. So I looked at Africa and tried to educate myself a bit more about the different regions within it. And for example, when you look at the north, I thought, oh, okay, we all speak Arabic. Well, not really, because out west here, they tend to speak more French, and their data is collected the French way. And so, if you move across, it's just not the same, basically. And this just goes to show there's a lot of diversity in Africa, economically, linguistically, and technically. So if you want to, because of the way data is procured. So, these are just things to look at. And I think my last is my reference. There you go. Thank you. Hello.
Yes, thank you very much, Dr.
I'll take it next
Sugi.
time, I'm sorry.
You have really done a very brilliant job. No problem, no problem. Actually, what you were supposed to cover actually is wide, and wide. We all know that. So I believe everyone here is enjoying actually enjoyed the presentation, and I would have loved if we had much more time to spend. But unfortunately, we have to let go at this point. Basically, you have actually done what was expected. And personally, I have enjoyed every bit of what you have presented. I believe before we round up, we're going to have a number of questions which you will react to. But we would like you to rest for some moments. I would like to bring the third speaker, Dr. Raphael Akongbe, is coming up now. Well, the way Dr. Dosugi has presented, somehow she has seamlessly crossed into Raphael's, some way I can see maybe there's a bit of synergy between the two speakers. Something very beautiful happened there. So I will want to hand over to Dr. Raphael so that he can move us further to talk about the way forward for a sustainable post-COVID-19 era healthcare delivery using telehealth and telemedicine. I believe Dr. Raphael is ready. Thank you for coming. So you are on now, Dr. Raphael.
Thank you very much. I appreciate this great opportunity given to me. And I really enjoyed the two speakers that spoke earlier on. I would like to quickly share my screen. If you can just quickly let me in. Am I in?
Yes, you are. You are. We can see your screen now.
Okay, thank you very much. Now, we're to look into the way forward for a sustainable post-COVID-19 era of healthcare delivery using telehealth and telemedicine applications. Uh, Telehealth and telemedicine application is a very crucial tool in the present day healthcare system. And the use of these applications is not only peculiar to a particular professionals in healthcare system. Every professional need to have the full knowledge of telehealth and telemedicine in order to have a very effective and in a setting of constant change and confusing terminology, telehealth continues to gain ground in both developed and developing countries. Evidence shows that telehealth has been used in essentially all countries of the world, but it is embedded in few of these countries. Uses and the need of telehealth varies between the developed and developing world. The developing world struggles with both communicable diseases and non-communicable diseases, and with very few resources. And we have common clinical applications, which includes teleconsultation, telecardiology, which is talking about the transmission of ECGs, and also teleradiology and teledermatology. Telehealth is not integrated into existing healthcare system globally. The reason is not far-fetched. We have some reason, such as lack of proven large-scale operations, poor evidence-based, inadequate implementation, lack of attention of the soft side of the implementation. That is talking about the readiness to make use of this application in order to proffer solution to healthcare system in the country. For the developing world, there are reasons that can be more pragmatic, which includes limited resources, unreliable power, poor connectivity, and high costs for the poverty-stricken countries. Now, telehealth is poised to improve health and healthcare in the developing world, driven by both altruistic and profit motives. But to have the desired effect, telehealth must address very specific and evidence-based health need of each facility, region, or country. And the shortage of health workers and specialist services, and the required skills, upgrading and training, allowing the developing world to establish its own critical mass of experts. This will only be achieved by raising awareness, understanding of the use of telehealth and telemedicine, and ability regarding telehealth capability and limitation. And by the coordinated political and professional will of all those involved in guiding public and private innovation and telehealth integration. Now, looking at the telemedicine, we all know that telemedicine is the use of electronic communication information technologies to provide clinical services when participants are at different locations. Closely associated with telemedicine and is also known as telehealth, because telemedicine and telehealth both make use of telecommunication technologies to provide healthcare solutions to the patients. This term is often used to encompass a broader application of technologies to distance education, consumer outreach, and other applications wherein electronic communications and health information technology are used to support healthcare services. Video conferencing, transmission of still images, electronic health, which includes patient portals, remote monitoring of vital signs, continuing medical education, and nursing call centers are all considered as part of telemedicine and telehealth. Within existing healthcare facilities, a few key clinical staff members have often led the development of telemedicine applications. As a result of this, the initial telemedical services that are offered reflect the clinical specialties of those leaders. Leading examples in the past have included radiology, dermatology, cardiology, and also pathology. Telemedicine does not represent, rather, it is a tool that can be used. It is a tool that can be used by healthcare providers to extend the traditional practice of medicine outside the walls of the typical medical practice. In addition, transform healthcare itself by encouraging greater consumer involvement in decision-making and providing new approaches to maintaining a healthy lifestyle. Now, looking into the various applications that is available in telehealth and telemedicine, we have applications such as the one that focuses on the patient care, continuing medical education, research, video conferencing, transmission of still images, which I mentioned earlier on, electronic medical records, remote monitoring, and so much more. Now, we need to look into different types of telehealth and telemedicine technologies. And from the research made, we discovered that there are three types of telehealth and telemedicine technology. The first one is known as the store and forward. It is also known as asynchronous telemedicine. It is a method by which healthcare providers share patient health information, such as lab reports, imaging studies, videos, and other records with a physician, radiologist, or specialist at another location. It is unlike the usual emails that we are used to, but it is done using a solution that has been built in with sophisticated security features to ensure patient data confidentiality. It is an evidence way for patients, primary care providers, and specialists to collaborate, because they can all review the information when it is convenient for them. And the approach gives patients access to a care team that can be compromised, that can comprise of providers in different locations, even across long distance and different time zones. In a particular popular environment, it is particularly for diagnosis and treatment with certain specialties, which includes the dermatology, ophthalmology, and so on and so forth. Number two, we look at the remote monitoring. That is the second type of the telemedicine and telehealth technology. Remote monitoring is also known as the telemonitoring, which is a method that allows healthcare professionals to track a patient's vital signs and activities at a distance. This type of monitoring is often used for the management of high-risk patients, like those with heart conditions and people who have recently been released from the hospital. Remote monitoring is also extremely useful for the treatment of a number of chronic conditions. It can be used by diabetics, for example, to track their glucose level and send the data to their doctors. Elderly patients at home or in assisted living facilities can be conveniently and inexpensively monitored through this telemonitoring. The third one is the real-time interactive service. And when you think of telemedicine, it is like real-time video visits that comes to mind. During a real-time telemedicine encounter, patients and providers use video conferencing software to hear and see each other, while the other types of telemedicine are used to enhance traditional in-person visits. It is popularly for primary care, urgent care, follow-up visits, and the management of medication and chronic illness. It is also important to note that the consumer video communication applications that we use to connect with friends and co-workers, such as Facebook, Skype, WhatsApp, are not appropriate for telemedicine practice. Telehealth should be conducted using technology that has been designed to protect a patient's privacy and meet the patient protections policy. Each type of telemedicine gives providers another way to deliver effectively and also efficiently as well. And they expand access for patients and provide a more convenient way to get the care that the patient needs. Now, I will quickly look into, because the time is far spent, to look at the impact of telehealth and telemedicine in healthcare deliveries. I mean, considering this post-COVID-19 era. Telehealth and telemedicine, telehealth and telemedicine are very essential, and they are fast-growing industry in healthcare system. The original goal of telemedicine is healthcare services to patients in remote or rural areas where the distance could be hundreds of kilometers away from the location of the facility, and offering a solution for problems such as shortage of medical professionals and healthcare facilities. Smaller hospitals in rural places are also able to provide intensive care services with the help of specialists in other facilities via remote patient monitoring system. The use of telemedicine has also expanded to reach patients even in urban areas, who are leading busy schedule and lifestyle. We have so many people who are working in the banks, so many who are working in the engineering firms, and sometimes the schedule of the job may not permit them to go to the hospital. But with the use of telehealth and telemedicine, they can still be at place of work and communicate with their doctors, and they will be attended to. Uh, it is less willing to waste their time traveling to the hospital or clinic and waiting in line at the doctor's office. Patients are looking for more convenient ways of accessing on-demand and immediate care. There are homebound patients or those dealing with chronic condition that are also able to benefit from telemedicine technologies, which allows them to share real-time medical information, such as blood pressure, heart rate, and other vital signs to their physicians in case of emergency. Now, when we look at the impact, just as we have said earlier on, the first one is it provides comfortable and easy to access of care, which I've just mentioned. That is, it allows patients who are living in a very far distance to be able to access the medical facilities in urban area through the use of this telemedicine application. The second one is it provides cost reduction in healthcare delivery. Telemedicine helps patients, medical providers, insurers, and even employers to reduce healthcare costs and save a lot of money. And unnecessary non-urgent emergency room visits or physical checkups for diagnosis of simple health issues like sore throat, skin rashes, cold, or flu may be eliminated through the use of telemedicine, which in turn can help patients save on transportation expenses and higher cost of in-person visits. More expensive hospital visits can also be significantly reduced for patients with chronic condition through the use of remote analysis and monitoring services. Telemedicine services can also help businesses and employers as well as their employees to save time and money by reducing absences from work and billable expenses incurred from the hospital visits. Aside from cost saving for patients and employers, telemedicine can also benefit medical providers. Instead of providing free over-the-phone consultation during non-clinical hours, doctors can now turn their on-call hours to billable time, which is going to be much more profitable to them. The third one is it provides easy access to medical providers. This access that is being talked about, if you look at the screen here, you will see that a lot of people are just waiting here to see doctors. And you will be surprised that in this particular clinic or hospitals, you may not have more than 2 doctors attending to these throngs of people here. According to the Nigerian Medical Association, that is 2019, there are only 40,000 doctors in an estimated population of 196 million. The latest data from WHO reveals that Nigerians' physician to patient ratio is 4 doctors per 10,000 patients, and patients often wait hours to see their doctors. And the patient in rural or remote areas endures longer travels just to access specialists and life-saving treatment for specific diseases. Telemedicine improves patients' access to specialists. It allows patients to have relaxed mood to relate their condition with the specialist while using this application. It also widens the patient population for a specialist, helping them to overcome geographic limits and expanding their reach. The fourth one, excuse me.
Hello,
Hello.
Dr. Raphael?
Yeah, can you hear me?
Yes, I can. Thank you. Sorry, we have very few minutes to go. So maybe you should just help us to speed up so that we can round up. Thank you.
Okay, okay. Thank you very much. Now, the fourth one is that it enhances health outcomes and good healthcare qualities. Telemedicine offers care that is patient-centered in that it provides patients with quality care when they need and where they need it. So it allows the healthcare givers to be able to communicate effectively with the patients. Number 5 is it increased in patient engagement. Now, telehealth provides a very great opportunities to patients to be able to have access into their health conditions. Patients are becoming more health tech savvy and even more aware of their health, and which we need to give kudos to the telemedicine application, which has been able to allow every patient who are tech savvy to have access into their health. In conclusion now, telehealth has helped expand access to care at a time when the pandemic of this COVID-19 has severely restricted patients' ability to see their doctors. Actions taken by healthcare leaders today will determine if the full potential of telehealth is realized after the crisis has passed away. One good thing that has come out of this horrible pandemic and all this suffering, cost of life, resources, and social and economic disruption is that finally everyone is realizing that telehealth, telemedicine, remote connectivity, and communication make a huge lot of sense. We have been struggling for decades to get telemedicine adopted to change the culture of the healthcare community, to embrace telemedicine, and for regulators to change regulations. To get administrators in hospitals to have the vision that is virtually connectivity is not a substitute, but a complement to what we do through physical contact. And it has happened quickly because we have had the desperate need for it. Thank you very much, and I really appreciate question. Thank you very much.
Thank you very much, Dr. Raphael. We are so grateful, and sorry because of the time factor. We do not want to so much exceed the time slot that we have, of course, announced that we will do everything within 2 hours. although we have extended for about another 15 minutes now, and we want to use that for questioning. Questions that border on all the presentations from the first speaker, Ms. Amano, to the second speaker, Dr. Eldosugi, and of course, the presentation we have just heard from Dr. Raphael. So if you have any question, our host just indicates by raising your hand so that our host can give you the opportunity by unmuting your speaker so that you speak. And if you don't want to do that, just drop it in the chat box so that that can be read out on your behalf. Already we have a question waiting, and it's here. I want to read it out, and I would like Dr. Raphael to help us to react to that question. It says, what is the difference between telehealth and hospital management software? The difference between telehealth and hospital management software. Dr. Raphael.
Okay, thank you very much. There's the difference between the hospital management software and telehealth. Now, the hospital management software only focuses on the activities that takes place within the hospital environment. And talking about telehealth, telehealth is a technology that covers beyond hospital environment. That is talking about those people that are not able to come into the hospital because of their distance. So telehealth, is extended into remote or rural areas where patient does not have the ability to come over to the urban area to receive treatment. So through this telehealth, patient can, the physician can software only takes care takes care of the activities that is within the hospital environment. Thank you very much.
All right, thank you, Dr. Raphael. Before I ask another question, there is a reaction from one of the participants by the name Gabe, and I think he's trying to, and of course, he made his own perspective also known about how telehealth, telemedicine applications can be done, especially in rural areas, in order to make it work better, especially in most part of. Thank you very much, Mr. Gabe. And I have another one from Mr. Michael Adiojo. Also to Dr. Uda, it's obvious that the challenges of implementing telemedicine applications in low and middle income any countries are huge. So the question is there any blueprint or plan to assist these nations? Wow. So I think I will give that to Dr. Eldosugi to react to. Any blueprint to assist the low-income nations in order to meet up with and of course to cope with the challenges. Dr. Eldosugi.
Hi, thank you for that. Yes, the WHO, excuse me, the WHO has it on their website, and it's a toolkit for low and mid-income countries, and it's free. You can literally Google it, and it's available.
All right. So thank you very much. I think that is very helpful. That is very helpful. Of course, still expecting one or two more questions. And while we're waiting for that, I quickly want to say a few things, to all our participants. The inspiration for this webinar actually was born out of the fact that we've had several discussions, webinars, and talks on how telemedicine and telehealth applications can be deployed, of course, during a pandemic era like this COVID-19 situation. And not many of these webinars and talks have addressed the socio-economic aspect of uh, you know, that COVID-19 has actually made the whole world to see or to face. And I want to appreciate Dr. Eldosugi. She has actually done justice to this aspect of today's webinar. Of course, I believe definitely we couldn't have had a better speaker for that aspect. So she has actually done it well. I believe now that all our participants, scattered all over Africa and beyond, we've been able to learn one or two things, and our perspectives have been open. The horizon has been broadened for us. Basically, things will get better, and the post-COVID-19 era will not be so challenging for us to cope with. So thank you very much. It seems we are not having more questions coming in, and I will just give maybe 1 or 2 minutes to our speakers. Ibijoke is no longer with us. I can see that. And I will give like 2 minutes to our speakers that we still have with us, Dr. Eldosugi and Dr. Raphael, just to, give us their thoughts and, maybe advice in a way. And of course, any other thing they feel like saying to the audience. So, and after that, we will do the vote of thanks and then we'll round up. Dr. Eldosugi, the ladies first.
Sorry about that. I was trying to find the guideline or for the toolkit for the blueprint for the framework for telemedicine. I was just looking for it, so that's what I was busy doing. But if I find it, I'll email it to yourself. You could forward it to the listeners, to the audience.
Okay.
Thank you so much for the opportunity. This was really great, and I hope it's one of many. I hope we have more of these, and I really think Africa needs to collaborate a lot more. All us African countries talk together and share best practice and see what experiences you've had and learn from them, and vice versa.
Yeah, well said. Thank you very much. Need for collaboration and of course to work together, build synergy. Of course, Africa is united, and of course, I believe this unity. With this unity, we can even achieve much more in every facet, economic, healthcare, and more. So thank you very much for that, Dr. Eldosugi. Now going to Dr. Raphael, your thoughts in a few minutes, a few seconds. Dr. Raphael.
Thank you very much for the opportunity. I just want to let the participants to know that adoption of telehealth and telemedicine is something that we need to embrace altogether as health professionals. People shouldn't just see this aspect of healthcare as something that is much more tilted to a certain medical professionals, and thereby leaving that responsibility to them alone. And for us to be able to be relevant in this present day healthcare system, every health healthcare workers. What I mean by healthcare workers, all those people that are working in the hospital, all the professionals need to embrace this technology. And with this, I believe that we can all make the healthcare delivery system to thrive more in our society. Thank you very much.
All right, thank you very much, Dr. Raphael Akongbe. It's been very nice having you, speak on this program today, and so much appreciates you. Also, in absential, I will thank Ms. Ibijoke Amono for the incisive and, of course, insightful presentation she gave. Of course, she has actually delivered something that is thought-provoking and, of course, a challenge to all healthcare professionals, be it medical professionals, allied health, or whatever area in healthcare that you are engaged. She has given us that advice, a challenge that, of course, you can move forward, you can do better, you can acquire more skills, and you can actually be a better version of yourself professionally, and of course, contribute more to the our healthcare industry. So thank you, Ebijoke, for that. Dr. Eldosugi, I can't thank you enough. Thank you for your time. Thank you for speaking. At some point during your presentation, one will find it difficult to actually tell if you are actually based in Africa or you are, based in the US. Of course, I know you are based in the US, but you have a very good understanding of what happens here in Africa. Of course, being a Sudanese also, which of course is Sudan represents most of African countries. The condition there is not too different from what we find in most African nations, be it in North Africa or Sub-Saharan Africa. So you've really done a good job. And of course, we hope that when next we call you to be a part of a future webinar, you will oblige us. Thank you very much, Dr. Eldosugi. Dr. Raphael, you let me say you are one of us, and your contribution, of course, we cannot overemphasize. You have spoken as somebody from the inside who understands the challenges, and of course we thank you for that. So of course the largest part of the appreciation goes to the participants who have, taken out their time to be part of this program today. I want to appreciate you. And of course, before we round up, we'd like to appreciate all our partners, everyone who has, one way or the other, we have some partners and sponsors. They have been part of this program, not only this webinar that we just had now, but they've been with us. So I would like to mention some of them. We have the Renaissance team. That is actually a group who has been working day and night to make sure that this happen. And every member of that team have really done a great job, and they have made this to happen. And we can only thank you. The knowledge, the understanding, and of course, everything you have put in, the resources, the time, it has actually proven to work well for all of us. So thank you. Also thanking Healthcare Coding and Technology Institute Lagos for being a good partner to this course. Also, Metro ICD is a partner, and of course, we enjoy your partnership. Yeno Enterprises has also contributed a great deal to this course. And last but not the least, we have DataLex Express is also a partner and a sponsor for this webinar. And not only that, this company has actually given us some gifts for some of the participants today. 10 persons who have participated in this program, especially those who are students and who participated in this webinar today, will be given some gigabytes of data, free data, for a period of time. I think the host will select, having determined the parameter to use, will select those who are students who are on this webinar today. And of course, you'll be contacted via other means of communication. So in all, we want to thank everybody for being part of this. We believe that the future is actually very bright. And of course, the navigation into that future will be very easy. It may not be very easy, but with people like you and with the knowledge God has given all of us, we'll be able to navigate with ease. Thank you very much once again. So, as it is, we have come officially to the end of this webinar. Thank you very much. We are grateful having you with us. Goodbye.
Thank you. Bye.